The day to day, the scope of the health challenge we are facing is really enormous. We have rapid urbanization with increasing poverty, and coupled to the unfinished agenda of the Millennium Development Goals, and still so many infectious disease and mother and child health issues, compounded with the threat of emerging new diseases, such as we saw with Ebola. And on the other side of the crossroads, we have the non-communicable diseases, who are rising very, very fast, and whose rise is not counterbalanced with the decrease in infectious diseases yet. Non-communicable disease occur mainly in low and middle income countries. It has been the disease in the past of developed countries, but this is not the case anymore. 4 out of 5 deaths of non-communicable disease are occurring in low and middle income countries, and 80% of the whole morbidity and the disability due to non-communicable disease is located in low and middle income countries.
So the 1 Million Community Health Workers campaign, we were launched in 2013, and since then we've been working with numerous partners in over 10 sub-Saharan African countries to respond to the demand of brainstorming and planning for the scale-up of CHW programs. Our mission is to accelerate the attainment of universal health coverage in rural sub-Saharan Africa via community health workers, and we aim to achieve this through advocating for CHWs to be acknowledged as a formal health worker, providing technical assistance to governments and partners who share this vision, and urging international and domestic financiers to increase support for the CHWs. And so here we are in 2015, where the campaign success will be defined by your success in scaling up community health workers in your countries. This workshop is an opportunity for all of us to discuss what we've learned through our successes and failures, and return to our respective countries and not repeat any mistakes, and fine-tune small-scale successes and produce larger-scale results that will provide health for all.
Basically, our system, the community health strategy, started in 2006. In 2005, actually, in our national health strategic plan, it was seen that we are having worsening and declining health indicators. So we thought of coming up with something that will reverse these declining indicators. And since 2006 and 2014, the indicators in brackets actually show the Kenya Demographic Health Survey of 2009, and the ones that are next to the indicators are the ones at 2014. So there is some progress, but there's still a lot to be done. One of the indicators which I did not show here, but at least it involves community health, actually is immunization. It's not doing well. We were at 87, we have actually currently gone down to about 70. So it's not doing well. So it means still we need to do a lot of work in community health.
The sector is guided by strategic health sector strategic plan. At the moment, we've just finished the health sector strategic plan 3, and we are working on the health sector strategic plan 4, which will it's a plan for 5 years, and the implementation will start July this year. And the good thing with that, the theme for the coming 5 years is the healthcare at household level. So you can see the component of community health workers has strongly been embedded into the plan.
You can see from the presentation that active community health worker system were triggered by something. In the case of Liberia, Sierra Leone, you see how the EVD, the Ebola virus disease, activated the need for community health worker system. And because this was supported either by donors and country efforts, political will, it got the problem solved. As in Ghana here, we also can trace back how we use community-based agents during the wake of Guinea worm. And we activated community-based agents and we got it solved. So this brings home that if we make sustainable effort to systematize or professionalize community health worker system, we can agree that we can solve a lot of our health challenges.
When you talk about health work, there must be regulation. There must be, registered somewhere. And also, how are we going to ensure that even their curriculum is something that is acceptable? And at the same time, how are we going to ensure that once these community health workers are trained, they go back to serve the community?
What we find in our country is that one of the reasons why it hasn't been sustainable is that you must pay them to provide this service. So how are you going to tell us, you need to tell us how you're going to have a sustainable community health workforce without paying them to do the things that you want them to do?
Well, firstly, everybody wants to be covered by good health services and not have financial worries about it. It's a universal need. It's also a very easy need to articulate and understand. Everyone gets it. Everyone gets it that, I want health services. I, don't want to be bankrupt from paying for it. So politicians can talk to electorates about it. This move towards progressive public financing, forcing some people to pay more than other people, is massively political. Ask President Obama about this in the United States. It's hugely political. You are also going to get opposition from powerful interest groups who aren't going to want to do that. They prefer their own arrangements. But also, why politicians love it, it can bring big results quickly to the entire population.
With the introduction of national health insurance, where community health officers tend to stay and give curative care because they want to get IGF, they tend to be overloaded with work. And to be overloaded with work, then it leads to the need for tax shifting, and that's where the community health worker, trained community health worker comes in. Who are the community volunteers? The current situation is that these are community members, most of them are semi-literate or illiterate. They assist the community health officers, and they do the work at their free time. They don't have any standardized reward system, and so most of them are elderly. There are volunteers according to various programs, as I mentioned earlier.
I would like to make it clear from the beginning that Uganda does not have community health program in the sense that we are discussing here. What we have is called the Village Health Team Strategy. And this Village Health Team Strategy has remained informal. Despite the fact that we have implemented it for the last 15 years, it has never been formally incorporated into the healthcare delivery system. Our village health system does not have a separate policy on its own. It has a document which I could say is both a policy document and also an implementation guideline. But the experience over the years has shown us that it is extremely important to separate these two documents. If you are to implement a good community health program, you need to have a separate policy which is very clear, which outlines all the key issues that the different players will meet down the line. You may see from our own self-assessment that we didn't score well at all in the issues of harmonization. This is self-assessment, and we were very, very, very clear about this. We scored below 40.
That scaling up a program is not simply a training cascade. By saying you're training CHWs, that doesn't mean that you've just scaled up all your CHWs. 2, scaling up a program requires scaling up various operational parts. So if you're scaling up a program, you're not just scaling up training, you're scaling up supervision, you're scaling up supply chain, you're scaling up referrals, you're scaling up governance. 3, growth of any of these operational methods can happen in different ways. And those different ways depend on local conditions, local context, local policy. 4, how you grow a program at the outset. So when you bring a program to scale, that's going to have different costs associated with it and different methods associated with it than when you're actually operating at scale. And finally 5, as we are at a costing workshop, the costs and the financing will differ greatly based on the types of methods you choose to scale these types of programs.